Um, the slide you have now, what does the positioning evaluation include? The very most important thing in evaluating wheelchair positioning would be identifying the goals. Before we do that, how many of you, ladies and gentlemen, are involved in wheelchair evaluation? You can go on the left and vote yes and no on the left-hand side if you have done any wheelchair evaluation. Okay, Hanan, you said you have experience with that. How often do you do that wheelchair evaluation with neuro patients? You can. Highly involved in the specialist daily basis. Okay. What about other people? How often are you involved in this evaluation for wheelchair positioning? Nina or Shaima, are you guys involved in that? Okay. One of the things that I do that often enough, but now since I'm teaching I see clients, not very often, so I see clients once in a while. I used to do that all the time myself. But the most important thing about wheelchair positioning, before we get started on the actual evaluation, is any therapist with the knowledge and expertise can certainly do that. It doesn't have to be a physical therapist or an occupational therapist. I also have seen nurses who does that. So anybody with expertise in that area can do the evaluation. So it doesn't have to be a PT or OT. Therapists are usually good at that. I have seen also sales representatives who would do that once in a while. And since they are not medically trained to do that, it might not be the easiest thing for them. So therapists, nurses, rehab doctors are involved into that. So it doesn't have to be any one particular discipline. Anybody with comfort level or the knowledge is highly encouraged to do that. The first thing we need to do or included is identifying the goals. And what we mean by this is, what are the goals of the positioning evaluation? Normally, what you would see is there is in the legislation too. Exactly, yes. You have to know your practice area. Hanan says it depends on the legislation. You are correct. I mean, you have to be familiar with your practice act in the city or the country where you are. If there are certain regulations or you have to have special certification in that, then you really have to be familiar with that. That's a good point. Thanks, Hanan. Otherwise, you might be losing your license, I guess. Identifying the goals, what I mean by that is normally you would have a client with an existing wheelchair system. You would think of somebody, for example, who had 20 years spinal cord injury. They do have a wheelchair already. So the goals for the client like that would be to see why they need a new chair. The old chair they have is either getting old or malfunctioning or breaking apart or something. So you need to know why do they need the new chair. And for a client who has a wheelchair already, you need to know what has worked in the past and take it from there. I have seen clients in the past who have chair for 6 or 7 years and the chair is getting old, but it's very comfortable. They don't want to give it up. The chair serves the purpose basically, and they just want an identical chair that just looks like the one they have. So those are your clients who have disabilities. The other kind of clients is obviously your pediatric clients, for example, who have never had a chair before and they need one. So those are, you have to start from starting point with an evaluation. And the third category is adult with new onset of diseases or conditions. Like think of young person with fresh spinal cord injury or a fresh stroke, for example. Those are will have different goals. No matter what the situation is, the main and the most important goal is function. The chair has to be able to facilitate function and interaction and socialization for the client. And it is obviously substituting for their lack of mobility, so they cannot walk anymore. So what we need to do is allow them, give them sense of independence, sense of function, dignity, participation in work, participation in fulfilling their roles in their community. Creating a profile of the patient, include their medical history, obviously. When you include medical history of the client, you need to know their current diagnosis. And the most important thing about that is knowing whether the disease process they have is progressive or not. Some diagnoses may get better with time. They might progress, possibly stroke, for example, new onset of stroke. They might get better with time, so they may not need a very high-end wheelchair. Spinal cord injury, it's kind of maintaining functional level that they already have. Progressive neurological diseases, Parkinson's, Lou Gehrig's disease, and those things, those get worse with time. So you really have to think about, adapting the chair down the road. So you really have to know the prognosis of the disease for the client, which is it's common sense, but sometimes we forget to do that. And performing the functional assessment. Obviously, the most important thing for the chair is to be able to function from. So once you prescribe a chair and you issue it to the client, you have to observe them doing functional tasks. The physical assessment and positioning assessment. This would be the bulk of the lecture for today. So performing the physical assessment is what we will focus on, and I will, the next slide will tell us exactly what we will focus on today. Simulating support and mobility. Once you get the client their wheelchair, you can do support system, cushions, lateral support, thigh support, hip support, and also mobility, so they can be tested. And there are standardized tests for evaluating wheelchair mobility once the client has been issued their equipment. Identifying funding information is obviously very important, because you can prescribe a chair, but if there's no funding, then the prescription is really not valid at all. So you really have to think about who is paying for the chair. Is it private, out of pocket? Is it insurance? Is it some type of hospital or charity? So you need to know how much money do you have to spend when you are prescribing this chair. If you have any question, go ahead and write them on the side. I'm keeping an eye on the sidebar here. So as I'm going, I don't want to be going too fast or missing important information. So if you have any comments, please write them on the left side, and I'll try to scan through those as I go. Today's presentation, we will identify measurement needed for proper wheelchair fit. We will talk about the most important things that we need to measure. Positioning evaluation for pelvis, mobility, hip and knee range of motion, ankle, foot mobility. And briefly identify some of the principles of seating solutions. We usually try identify measurement needed for proper wheelchair fit. So this is our starting point usually. And what we need to do is get the best fit for the client for their functional needs. And the model we use for that is called HAT, H-A-T-T. I don't have that written down, I guess I can. HAT, I don't just swear up there. HAT means or stands for a human, A stands for activity, and AT stands for assistive technology. So this is basically this is the way to think about how to evaluate somebody for a wheelchair. In this case, assistive technology stands for wheelchair. The human factors that you need to identify include obviously the client's range of motion, the client's motor profile, the client's coordination, strength, range of motion, the client's cognition. So all the factors that have to do with the client themselves, the human factors. And they include strength, range of motion, coordination, head support or head control, trunk control, cognition, memory, orientation, and like we said earlier, the disease process. A stands for the activity, which means what activity is the client going to be involved in when they are doing this, when they are riding their wheelchair. So the activity could be home-based, for example. So if the client needs a wheelchair for home, the chair will look different than if the client needs a wheelchair for community access or to work for 6 or 8 hours out of the day outside. The assistive technology in this case, like I said, is the wheelchair too itself. So the wheelchair, the properties of the chair, is it reclining back, is it standing wheelchair, is it manual wheelchair, is it power wheelchair, or is it a hybrid wheelchair, is it sport wheelchair, is it a low profile wheelchair, or is it a hemi wheelchair? So the assistive technology piece, which is the wheelchair, what are the properties of the wheelchair that the client needs to fulfill his or her activities, giving their human factors. So this is how we identify the proper wheelchair fit. Next point is the positioning. The positioning evaluation for the pelvis mobility, the head, the knee, range of motion. We will look at those in more details here in a few minutes. And as we identify the evaluation for the mobility, we will talk about some of the principles of wheelchair solutions. The therapist should cover, in an evaluation, the therapist should cover pelvis tilt or pelvic tilt. It depends on what accent you have. Pelvic tilt, it can be neutral, posterior tilt, or anterior tilt. And I have a slide here in a minute. I'll show you. But the pelvis in a human being, I guess, we are created to be standing upright. We are not meant to be sitting down constantly all the time with the 90 degrees flexion at the hips, with 90 degrees flexion in the knees, and that's what wheelchairs do. We are created to be upright and standing. So when you put a human being who's supposed to be standing, you put him in a sitting position all the time, the center of gravity change, also the weight distribution and the weight pressure on certain areas of the body shifts. So the pelvis in this case, instead of us normally standing up on our heels and our feet, now we are sitting on a pelvis that's not meant to support us for a long time. So you might see some deformities or change of the pelvis, how it looks. One of those, again, it could be neutral, posterior tilt, and an anterior tilt. We will look at what does that mean and how do you actually evaluate for any of those. Same thing for pelvic obliquity. Obliquity, again, can be neutral, which is everybody who's normal. It could be the right side is higher, and it could be the left side is higher. Just keep that in mind, and I'll show you a picture here in a minute again. Pelvis rotation, it could be neutral, which is the normal. The right side could be rotated forward, or the left side could be rotated forward. Hip flexion, range of motion, we measure that using goniometric measurement, and we measure both the right and the left. Same for the knee extension. We have to check the client's range of motion of the knee, and again we do that with goniometric measurement. Hip abduction and adduction, we look for neutral. Is neutral achieved? So we have to check for if the client is adducted or abducted at the right and the left, if it's a fixed deformity or if it's a flexible deformity, and if it's flexible, can we achieve the neutral? Same applies for numbers 1, 2, and 3. So if the client has any tilt in their hip or obliquity in the pelvis or rotation in the pelvis. So the question is always is that rotation or obliquity, is it fixed or is it flexible? With fixed deformities means basically that the client's pelvis is stiff, basically. They cannot get out of that position, and that's usually with prolonged disabilities and chronic conditions. And think about somebody with a 20 years stroke, for example. They get stiff, their joints get calcified, and they cannot get out of that position. Typical example is elbow flexion, for example. You have somebody who with a new stroke, they can extend their elbow even though they might have high tone, but as the years go on, they get stiff, they cannot open up their elbows, and that deformity becomes fixed now, so you cannot do that. Instead of the elbow, think about the pelvis in this case. The neutral or the posterior tilt or the anterior tilt, is that always fixed or is it flexible? Flexible deformities, you can sorry, I think I drank too much coffee this morning. Fixed deformities, you have to accommodate for them. You cannot change the deformity. So what you need to do is you need to build up a positioning system or cushions or support that accommodates, that's the key word, for the deformity, because you cannot fix it. So you need to redistribute the weight correctly when the client is sitting in their wheelchair. So to distribute the weight correctly, you need to accommodate for fixed deformity. Flexible deformities, you need to fix those by providing lateral support or different cushions or different ways to correct that deformity. So at each and every one of those, always think, is it fixed or is it flexible, the deformity? And again, that applies for, numbers. That applies for number 1 and number 2 and number 3. So those rotations and are they fixed or flexible? Same thing for hip flexion. Hip flexion, you have to have enough flexion at the hip to get a client in a standard wheelchair. Standard wheelchair, most of those from what you have seen, the trunk will come in toward the end. Actually, Hanan, there's trunk and spine. I might have. Let me look and see. Trunk and spine are also important. Thanks, Hanan. Hip flexion. Ideally, you would like to maintain the client's hip at 90 degrees. But if the client cannot flex their hip at 90 degrees, and that's what most standard wheelchairs do, then you need to give a client a different equipment, a different wheelchair that can open up to 70 degrees, for example. You measure the client's, we don't do a whole lot of measurements on hips and knees as OTs, but if you remember your anatomically correct position, the client is laying supine on their back, and then they flex their hip. So, anatomical position with the hip fully extended, that's your 0. You flex the hip, to 90 degrees. Anything over that it will be like 100 to 120 degrees is the maximum flexion you can do. But if the client only can flex to 70 degrees, you cannot sit the client in a wheelchair that is 90 degrees back. So the client has to be fitted in a different wheelchair, a reclining back wheelchair, for example, or accommodate some type of cushions too. Same thing for the knee extension. You start off with the knee fully extended, and then you flex to, I think, 135 degrees or something like that is the full flexion in the knee. And if the client cannot sit at 90 degrees flexion at the knee, then you have to accommodate for that. Same thing for hip abduction and adduction. And number 7 is your foot position and weight bearing. For the foot, we sometimes tend to ignore that, but weight bearing on the foot, it could be on the sole, which is like me and you and everybody else who's walking upright. Some people do Some people do medial weight bearing, which means their foot is inverted. And some people do lateral weight bearing, which means their foot is the sole of the foot is facing outside, and some people do weight bearing on the toes. So, the position of the foot is important to determine what type of foot plate you need to give the client. So the client has to sit with foot rests and foot plate. Is the foot plate flexible? Is it fixed? Is it adjustable? Is it one axis? Is it two axis? So to get the client the best fitting foot plate, you have to know how their foot is positioned. And last but not least, like Hanan said, is the spine and trunk. Well, he might come out at you. Anyhow, so you need to also know the position of the spine. You want to tell us about that, Hanan, since it was your idea to talk about the spine? What do you mean by spine and trunk? Okay. Upper extremity. Alright, so Hanan is saying spine and shoulder. So what you need to do is identify if you have any rotation, any curvature of the spine. You need to also identify if there's any scoliosis, which is lateral bending of the spine, and so on and so forth. So for the trunk, it's either within functional limit or neutral. It could be kyphotic with kyphosis or lordosis. Or it could be also, if you look at it from the, it could be curved sideways, scoliosis, and also it could be rotated. Like one shoulder will be forward and the other shoulder will be backward. So you look at the trunk and the spine from the side, and it could be again, kyphotic or lordosis. It could be curved. Such as in scoliosis, and also the last thing is you actually look at the client from over their head to see if there is any the shoulder is forward or backward. So that would give you an idea about the rotation. Other deformities which might suggest further compromise. I'm not sure. What do you mean by that? Like if they already have existing deformities, for example. Okay. And also, Shaima asked about the upper extremities. Upper extremities are definitely important, and that is when you check for the function. But when the client is seated in a wheelchair, their base of support is their pelvis, and that's why you always start with sitting balance and pelvis assessment of the pelvis and the lower extremity. I mean, that is what your weight-bearing surface is now. Your upper extremities, you're not weight-bearing on the upper extremities. You're not using them to hold you. You're using them for function, and that's why when we, the previous slide. This slide is when we talked about functional assessment. This slide here. I mean, function is very important. Everything revolves around function. I mean, if the client is not functional in the wheelchair, that means their upper extremities are are they cannot use their upper extremities. So always think function. I mean, that's why you put clients in wheelchairs to start with. So they, again, so they can function, so they can go to work, they can do their ADLs, they can move around and take care of their ADLs or work and things like that. It is important to support the position of the upper extremity, and like I said, I mean, you are sitting on your pelvis. You know, think of yourself now as you are sitting. You know, for this presentation, your entire body is supported on your pelvis, your hips, your thighs, and you know, your feet give you support for balance. Trying to give you support for balance, but you know, anything proximal or distal to the clavicle, you know, your shoulder plates, your shoulders, your elbows, your hands, they should be free for function. You know, you should be supported as close to the center of gravity, in this case the pelvis, as possible. So if we can maintain your support from the pelvis by giving you a cushion, that's fine. If we need to move your support closer to the trunk, for example, you know, like a C6 or C7 spinal cord injuries, they cannot maintain their balance sitting up on their thighs and on their pelvis, because they will lose their balance. So you have to move up closer to away from the center of gravity. So you have to give them more support distally. And neck and head too, definitely. I mean, for your neurological clients with high involvement, I mean, it could be, you might have to even support the head and the neck for function. If the client is unable to use their hands and they are controlling their equipment, or you know, if they have a communication device they control with their eyes or with their head control or with their muscles of the face, they have to have some support to their head, exactly. So the rule of thumb for support, again, you support the least possible joints, or you immobilize the least possible joints to maintain function. So if you have to only, you know, your typical clients, they are okay sitting up in a wheelchair, supported on their pelvis and thighs, you know, but you might have to move your support more distal to the trunk, you know, like in spinal cord injury, for example. You might have to even move it further, more distally, to support their neck and head, such as in Lou Gehrig's disease and some of the other neurological conditions. You're right, Hannah. All right. We used to say, this is a side note, we used to say in the old days for occupational therapists, we used to say what you see on the fingertips starts at the hips. So if your hips are not supported, your fingertips are not going to be able to function correctly. So what you see at the fingertips starts at the hips. So you always have to have good support at the hips, pelvis, to get good functional use of your hands. And I know speech therapists actually say what you see at the lips, you start at the hips. So if the client is unable to swallow, if they're not sitting up correctly, supported and comfortable, they will not be able to use their lips to swallow and to communicate. So this is, you know, support is very, very important. All right, next couple of slides here, I'm going to look at pelvis tilt, pelvic obliquity, and rotation, and we will see what that actually means and how it is assist. This is, if you look at this is a pelvis, and ideally, this is right here is the what we call the ASIS, anterior superior iliac spine. Back here is the posterior superior iliac spine. And those, ideally, in me and you and normal functioning people, they should be at the same level. In this case, obviously they're not. The ASIS is way lower than the PSIS. So this pelvis is tilted anteriorly. So this is an anterior tilt of the pelvis. And having done that, the client is sitting on a very narrow area here. They're not sitting at, the weight is not distributed evenly. In this picture down here, their ASIS is much higher than their PSIS. So they're shifted backward, and they're sitting on their sacrum, basically. So they're sacral sitting, what we call it. So in a normal pelvis, the ASIS and the PSIS should be at the same level. If the client is anteriorly tilted, then their ASIS is lower, and if it's posterior tilted, then the ASIS is higher. And the ASIS is very easy to palpate. No voice. Somebody says no voice. Can you guys hear me okay? Yes, no? Hello? Can you hear me? Yes, no? Okay, all right. So everybody can hear, I guess, except one person. Shema, I don't know what the problem is. I guess you might want to check your audio setting or something. And again, if you have to go back to this session, it will be archived. Probably system takes a few minutes to get it done, but it will be archived, so you can always look at it again. So, all right, this is an example of an anterior tilt. Basically, this is, again, it's not functional, it's not good for the client. You have poor distribution of weight. Same is for the posterior pelvis. And if the posterior, obviously this picture doesn't have the spine or the lower extremity, but if the client is anteriorly tilted, usually that would affect how it will give them lordosis of the lumbar lordosis of the spine. So the anterior tilt affects the spine, and again it will affect the head, and it will affect the lower extremity. If they are posteriorly tilted, like we have over here, this is a posterior tilt. So this will give them kyphosis of the spine. So the position of the position of the spine will be affected by the position of the pelvis. Here you will have lordosis because you're trying to maintain correct position of the head. So the position of the pelvis affects your spine, which affects your head, and in turn it affects your upper extremities and function. So that's why everything has to start at the pelvis. And again, not only that, it affects obviously your weight distribution, and it makes you more prone, makes the clients more prone to different pressure sores in the area. The obliquity of the pelvis, we're not looking at it from the sideways anymore, like this picture here. This picture, for the tilt, you look at the client from the side, basically. This is a side view of the client. This one here, you're looking at the client from face to face or from the back. This is an anterior, posterior view. And again, in this picture here, this is your okay. If you look at the obliquity means this is the left ASIS, and over here is the right. So this is the right, because you're looking at the client from the front, as from frontal aspect. Over here, the right and the left are level, basically. They are at the same level. Over here, they're not. This picture here, if you draw a line in between the right and the left ASISs, they are, one is higher. In this case, the left one is higher, so we call this a right pelvic obliquity. So the client is oblique to the right, and obviously it could be, it could be the opposite, the other way around. And again, for this, if the client is like that, if the client's pelvis is like that, that means their spine is going to overcorrect for that. To get the head in an upright position, their spine is going to get convexed, so they're going to go sideways on the spine, and it will affect their shoulder blades. The left shoulder will be lower than the right shoulder in this case. So again, it will be, it will affect their function. So this is the obliquity of the head, and I'll go through how to evaluate that in a minute here. Yeah. The best way to check for pelvis tilt and obliquity is by having the client sit on the mattress. So you get the client sitting on those therapy tables or mattresses, and usually they're high enough for the client's feet to be touching the floor, but not way too high, so that the feet should not be hanging off in the air. Basically, the client should be sitting on the mat as close to 90 as possible, 90 degrees at the hips, 90 degrees at the knees and the feet as possible. Unsupported sitting is very important because, like we said earlier, you need to know how much support to give to the client. If the client can be a hands-free sitter, if they can sit with their hands free, that's fine. So the client transfers on the mat. What we ideally ask them to do is cross their hands, like put, yes, so just lying supine to allow full trunk support. You mean for testing, Hanan, or for assessment, or just for having the supine? Okay, yeah, that's my next slide, Hanan. Hanan is always ahead of the game. She's always been a smart student, from what I remember back then. So unsupported sitting is usually the best to assist the pelvis. Yes, actually you assist the pelvis in a supine position too. You observe it in sitting, you get on the mat in a supine position to get a good view of their pelvis. You do that again. We'll go over that in the next slide here. Unsupported sitting. When you sit the client on the mat, you first, the first task the client does is transfer off of their chair into the mat. So by doing that, you evaluate their transfer skills. Basically, is it safe? Are they independent? Do they need help? Are they dependent? So for one thing, you check off their transfers off of your list. And also the next thing is to see for them if they need support in sitting or not. Hands-free sitting is somebody who can sit without any support using their hands. Hand-dependent is somebody who has to have their use of their upper extremity or hands to sit unsupported. Hand prop is basically hand assistant, so they need some assistant, but they can maintain some of their sitting. And in this case, you are actually evaluating their trunk control too, because if the client cannot control their trunk muscles, they cannot control their sitting posture. To do that, the best way to do assist the unsupported sitting is, again, you transfer the client on the therapy mat or a table, or I don't like the hospital beds, because most of the cushions they use, or the mattresses, or the bed mats are just, they don't give you good support. I mean, the clients sit on them and then they sink. So ideally, you like to have it sit on a harder surface than the side of the bed. You ask the client to cross their arms across their chest, and not to use their hands, obviously, and you are standing by to give them support if they need support. Supine in the mat, like we have in this picture, the very first thing you need to do is you check for pelvis mobility or tilt. So what we get the client on their back like this, and this is a client with, if I remember the details about her, C6 or C7 spinal cord injury. So what we need to do is check for pelvis tilt. So what you need to do, even though I say forcefully, but of course you have to be gentle at the same time, the therapist here has her right hand, the therapist, right hand of the therapist is underneath the client's knee, and what she's doing is she's flexing the hips, and again, the hips will flex to up to 120 degrees or so, but what we need to do is actually clear their buttocks off of the mat, so that the buttocks has to elevate off of the mat for 2-3 inches, just to see how much tilt. If the client's buttocks come off the mat up like this, that means they do have anterior tilt of the pelvis, because the hips will flex up to a degree, and then everything after that has to come from the pelvis. So that's how you evaluate for pelvis tilt. So this is the pelvis tilt. This is the client's thigh. You flex the hips, and then anything after that, you're actually flexing the pelvis of the client. And this will be the anterior tilt of the pelvis. Now, what we said about the obliquity is basically the ASIS even, or are they one is higher. So this is our pelvis obliquity. So now in the picture we need to evaluate and see if one of the ASIS is higher than the other one. So what we need to do is lateral shift of the pelvis. ASIS normally are even. What we need to do is try to shift one up or down by bending client's knees. Again, this is over here. This is over here is the client's this is the therapist's hand, I'm sorry, and she's holding the client from underneath both knees, and what you need to do is bend the client's knees and then attempt to laterally rotate the trunk by moving the ISS closer to the rib cage. So the ASIS is here. What the therapist is doing is actually rotating the trunk to move the ASIS closer to the rib cage of the client. And what you do is you feel the client's ASIS over here to see if it has moved or not. So the therapist gets her right hand over here, and what she does is she bends to 90 degrees the hip, and after that you try to rotate the ASIS closer to the rib cage. If it does, then the client has obliquity, because the movement is coming from the pelvis. It's not coming from the hips anymore. And you do that on both sides, obviously. Over here, what you need to do is assist for rotation. And rotation of the pelvis basically means one side is higher than the other. So rotation, the therapist has one hand over here on the therapist's right hand is pushing down on this side, and then she's pushing up on the other side. So what we need to do here is evaluate if the patient has rotation at the pelvis. Place one hand on one ASIS, in this case the left ASIS of the client, and then the therapist's left hand goes under the other ASI. So one hand is over, one hand is under, and then you gently push down with one hand, push up with the other one. Trunk and shoulder should stay to the mat, or close to the mat. If the trunk or the shoulders start coming off of the mat, that means the client does have a fixed deformity. If they do not, if you can rotate the pelvis without any interference of the shoulder and the spine, that means the client does have a flexible rotation. Right. Any questions over those so far? So this one here, we looked at the tilt of the pelvis, and we said by flexing the client you can evaluate to see if they have anterior tilt or no anterior tilt. Over here you assess for obliquity, which means ASI is shift up and down. Over here, this is how you evaluate for rotation of the pelvis. Last and not least is obviously the lower extremity range of motion. Hip flexion, you do that. I think that was raised up earlier. You do the hip flexion. You do a goniometric measurement to determine if the client can sit in a 90 degrees angle. If the client cannot sit at 90 degrees at the hip, then they cannot be fitted in a standard wheelchair. That means they have to have a reclining back or a specialty cushion that accommodates for that. If you don't, that means they're going to be sitting, their weight bearing is not going to be evenly distributed, and we'll look at the picture here in a minute. Knee extension. A lot of times we forget about the knee extension, but it is an important part of the evaluation process. Hamstring is a muscle that attaches to the front of the frontal aspect of the back aspect of the knee joint, and it also attaches to the pelvis. So if you have a client with short hamstring and you try to extend their knees, it will pull their pelvis, and they're going to be sitting at their sacrum. Basically, it will posteriorly tilt their pelvis. So if you have a client with short hamstring or limited range of motion in the knee, and you try to extend their knee by using footrests or elevating footrests, you might end up sitting the client with their sacrum, so they will be posterior sitting because that hamstring muscle is attached to their pelvis, and that's why we need to check for knee range of motion. Dorsiflexion and plantar flexion of the foot and the knee is important. Inversion and eversion of the foot is also important, and you do that to determine what type of foot plate you need for the client. So if the client can have a 90 degrees dorsiflexion and their foot is not inverted or everted, that means we can put them on a standard foot plate. If not, we need to get a foot plate with multiple axles to accommodate for that, or maybe straps or something. And also the resting position of the foot, because sometimes they might have good range of motion, but their foot rests in a different position. And last, about the feet, a lot of times we do, of course, work with physical therapists to see if the client is using AFOs, for example, ankle foot orthosis, to accommodate for any deformities at the ankle. You also check for tone. If there's increased tone or decreased tone in upper extremities and lower extremities. You also check for skin, for wound, the location of the wound, the degree of the wound, and the cause of the wound, so to see if there's any problems with that. Last but not least is the pressure mapping. Okay. Oh, here we go. Okay, pressure mapping. Let me pause for a minute and see you're probably familiar with that. Anybody familiar with that? I guess I should ask, with the pressure mapping systems. Okay, 1 yes. 2 yeses. Okay. All right, I got 2 yeses. Anybody with an open mic can tell us what this is? So I feel that I've been talking for too long. So anybody?
Pressure mapping basically is a mat that you place under the pelvis while patient is sitting, and this mat has lots of sensory cells that assess the pressure on these cells. It depends on the distribution of these cells. Some mats are really good in the sense of very millimeters assessments. So the pressure is assessed on these sensors, and it gives a kind of, here in the, as Hosni suggested in the picture, the red is suggesting high pressure on these areas. You can tell from the picture that the left side having lots of pressure on the pelvis area, while the right is less. I think that's all.
Yeah, I think that's well said. Thank you so much. Yeah, that's well said. It is, like Summer said, what it is, it's basically multiple sensors. In this case, this is the one you're looking at is for a wheelchair. They have those for feet. They have those for full body pressure mapping. So the one you're looking at now is an 18 cell by 18 cell pressure mapping system, and it's very sensitive. I think so. In total, you probably have 300 to 400 pressure sensors embedded in the pad itself. So what you do is, ideally, the way this is done, it's an assessment tool, and also it's a treatment tool, if you will. So you have a client who comes to you with a cushion, and you want to see if their cushion is good or not. So you transfer the client out of the wheelchair. You put the pad. It's almost like a prayer rug, almost. It's very thin, Sajjadat Salah almost, and it's connected to a computer, and so it's very thin. It's not. It's not a. What am I trying to say? It's not like a board or a heavy surface or a hard surface that you sit on. It's flexible surface, and it's connected to the computer. So transfer the client out of their existing system. You put the pressure mapping sensors underneath him, and then you sit him back on that pressure mapping system. And what you do is you get a visual representation of their high areas of pressure mapping. Of course, anything in red, and it's 3D, obviously, like you see over here. If you look at the picture on the right side over here, the areas that are mountainous, like mountains here, it's very high pressure on those areas, and those are your sacrum, basically. Those are the sacrum of the client. So this client is not evenly distributed as far as their pressure. So once you do that, you give the client a cushion, a new cushion, or a recommendation, or a roll, or an air cushion, or a gel cushion, or foam cushion, and then you do the same thing again. So you do a pre and post assessment of the new cushion. So you get them with the old cushion, you get a print out of this, and then you make a recommendation and retest them again. And ideally, you would have as this red areas as possible, and that's if you have done that, that means you have done a good positioning system. I think this is the last slide I have, so I'm going to see if anybody has any questions, or not necessarily questions, maybe suggestions or past experience. Yeah, it is a good visual, Hanan. You're right. Hanan is saying it's a good visual for teaching and also, yeah, for pressure relieving exactly motion. So you could use that not only for assessment and baseline, you could also use it to educate your client. That's a good point. Thanks for that. You could use that as an education tool to tell your clients that you have to shift, and if you shift, this is what happens to your pressure distribution. If you don't shift your weight back and forth, this is how your pressure is going to be incorrectly distributed. So that's a good way to do it. Do you have one in your center where you work, Hanan?